Hi, I'm Vic Tapson. I'm in pulmonary critical care out at Cedars-Sinai Medical Center in Los Angeles. I see patients with pulmonary hypertension, pulmonary embolism, and pulmonary disease. So let's talk about how the pandemic has impacted patients with PAH. And many of you out there have lived through this and have a pretty good idea yourselves. There was this early hypothesis that PAH might somehow be protective and that somehow either PAH therapy or something about PAH would protect you from COVID. And I think what we learned pretty quickly was this wasn't true. And there were several publications out there that suggested this. One early, last year, mid-July, I think, Dr. Lee and colleagues published a paper in Annals of ATS offering their experience. And what they found in this paper was, it was a survey. The incidence of COVID-19 in patients with PAH or CTEPH was about the same as it is in the rest of the population. In other words, about 2.9 cases per 1,000 patients. And this was similar to the CDC population estimate, which is around 2.5 cases per 1,000 for the entire U.S. So PAH patients are getting COVID. Now, the states with the highest burden of COVID seem to have the highest burden of COVID in PAH patients, which sort of makes sense. Also should note that the outcomes for PAH patients with COVID was worse than the general population. So about 75% of hospitalized patients in this survey required ICU care. And one thing you might ask is, were doctors just more cautious? Someone comes in the ER with pulmonary hypertension, especially severe PH, and their pH seems to be stable, but they've got a bad case of COVID. They're probably going to go to the ICU, a lower threshold to go to the ICU. So if they get fluids and medications and things, they make sure their oxygen's okay. I suspect that might be the case. We're more careful. So that was interesting data that we found, and more data came up. Dr. Sulika in New York, where COVID hit pretty hard early on, published a paper in a journal called Diagnostic. Now, this is pretty recent. This was in January of 2021. And what Roxanne and her colleagues showed, and this is a retrospective study, but they have about 350 PH patients in their center, and about 11 of these patients got COVID. And most of the 11 had at least moderate or severe pulmonary arterial hypertension. So about 2/3 of these patients required ICU admission, and almost half died. 5 of the 11 patients died. So certainly COVID in patients with PH can be bad. This shouldn't be a surprise. I suspect many of you out there experienced some similar sort of numbers with your PH patients. Now, we know that New York was just going down in flames with COVID early on, and I don't know, could that have something to do with the morbidity and mortality in maybe publications or hospitals coming out of New York? In LA at Cedars, early in the pandemic, I like to feel like we didn't get hit as hard. We were lucky early on. Then it got worse, but we were ready. We were very prepared. So when we'd come in the hospital, we'd put hand sanitizer on. Someone hand us a mask, ask about symptoms, check our temperature, etc. And we'd go to work. And we had a little more time to organize, which may be why our mortality at Cedars seemed to be lower. You get hit hard by something like this, a COVID pandemic. And it certainly isn't surprising some of your sickest patients might not do as well. Well, bottom line here is, we thought early on, and maybe because we're being so protective, but we thought early on that maybe COVID wasn't hitting our PH patients. Maybe they somehow weren't susceptible. Don't think that's true. Certainly not a good message to tell our PH patients. And so we've done telemedicine clinics since the pandemic started. I've seen some live patients in the clinic, many live patients in the hospital. But for the most part, I think telemedicine's really helped us. And I think because we've been so cautious, we've gotten away with a lower mortality than we might have gotten away with otherwise. But bottom line here, the pandemic clearly has affected patients with PAH. So folks, now we're going to talk about the evidence or guidelines that we had available to reduce the risks in PH patients during the pandemic. So what did we do? And in terms of data, and again, I'll say this, that many of you out there kind of learned this and handled it and did it and probably understand kind of what kind of things needed to be done. There are some data that are published, however, and probably the two best journals dedicated to pulmonary vascular disease, especially PH, are Pulmonary Circulation, and that's a great science journal, clinical data, basic science data, and Advances in Pulmonary Hypertension, which is more reviews. I have to brag that I started Advances in Pulmonary Hypertension many years ago, and we one of the things I wanted to do with this journal was to use a roundtable discussion approach like they did in surgical journals. So we tried that. It's worked really well. So looked at those two journals for most of this information. Bottom line is, I don't think we really needed guidelines. I'm just going to say this. I think a lot of what we did was common sense. Now, nice publication by Dr. Ryan in Pulmonary Circulation, published in March of 2020. So this is early in the pandemic. Dr. Ryan did a really nice job of kind of outlining what we kind of needed to do, and the impetus of this paper was the PHA, great organization, Pulmonary Hypertension Association, great patient-oriented organization, and the PHA said we need guidelines, we need best practices by experts, and so we got these, and Dr. Ryan did a nice job with this publication. Early in 2021, there's a nice roundtable discussion, advances in PH, and it was on telemedicine. But what did we do? What kind of guidelines did we have? Well, the guidelines that we had suggested the information that we had, and our common sense said wear masks and social distance, of course, just like anyone else in the pandemic would do. Now, of course, there's vaccinations, and we want to tell our patients to please get vaccinated. Telemedicine was huge. Like I mentioned, Wendy Hill and I, we did done telemedicine clinic now for a year now, and we love it. We're all hooked on telemedicine. Certain things you can't do, clearly, but this did help us get through. This kind of helped us to get through the pandemic without exposing our patients too much. So one certain guideline many of us agreed with is don't expose patients any more than you need to. And we counseled patients on all these issues of vaccinations, mask, social distancing. One great thing that guidelines didn't cover so much or didn't emphasize so much, and that's support groups. I mean, I think support groups are invaluable in PAH anyway. Wendy Hill does a nice job at Cedars-Sinai organizing these. She does them on her own time on the weekend. I gave lectures on COVID drugs to PH patients, lectures on the trials we were doing in COVID therapy, lectures on vaccines. So bottom line is, while the PAH journals, Pulmonary Circulation Advanced PH, offered some nice suggestions and guidelines and great roundtable discussions, a lot of this was using good clinical judgment on testing. What do you really need? Do you need an echo? Do you need a 6-minute walk? Do you really need it? Do you need a BNP? Do you really need a right heart cath? And this kind of reminds me sort of how we used to handle lung transplantation when it first came out. We didn't know what to do. When did we biopsy? When did we look for rejection? How do we treat it? We just kind of used our heads, used our knowledge on pulmonary hypertension and COVID and put it together and didn't expose our patients. Lastly, let me just emphasize that in this early 2021 issue of Advances in Pulmonary Hypertension that does address some of these effects of COVID-19 on PH patients in the medical community, was a really nice review of things. And some of the things they discussed in this issue were health disparities in PAH and in COVID-19 and those together. PH and telehealth, nice discussion on that. Telehealth benefits and challenges for pediatric PH patients. The COVID-19's impact on PH clinical trials. So this is a great issue. Volume 20, issue 1 of 2021 is a great issue that offers some guidance for PH and kind of how to get patients with PH through the pandemic and through COVID-19. So let's talk about what changes we've made in our approaches to the diagnosis of PH during the pandemic. And let me start by saying, as you know, PH has been a tough disease to diagnose. First of all, it's fairly rare. The prevalence of PAH in the U.S. is probably about 20 per million adults, somewhere in that range. For pulmonary embolism, it's 1 in 1,000. So this is a rare disease. In patients with scleroderma, maybe 10% of those patients get PAH. So it's very common in scleroderma patients. It's more common in whites, certainly more common in females. The incidence in the U.S. is probably somewhere in the range of 500 to 1,000 new cases per year. So the bottom line is making the diagnosis of PH is important, but many clinicians out there just don't see it very often. So I think what many of us have seen in the past, which I think has probably gotten worse in the pandemic, is that a patient will come in, it'll be a 40-year-old woman, and she'll have had childhood asthma, and her family doc or internist will say, well, you know, maybe this is your asthma, let's try this inhaler, see if it works, and maybe the patient doesn't even have any wheezing, or they'll say, well, you know, you're kind of anxious because of this pandemic or because of some other situation, so it's It's probably anxiety. That's why your heart rate's 95 per minute. Or it's because the tough ones are when someone is told, well, you're pregnant, so no wonder you're a little short of breath. And then we see the patient goes 3 months or 6 months, sometimes a year or more, and doesn't get diagnosed. So this is a problem before the pandemic. And I think in many ways got worse during the pandemic, making the diagnosis of PAH. Again, and one of the reasons it's worse is because we don't want people coming in for testing unless it's necessary. So we would do things on phone calls. We would do telemedicine visits for patients during the pandemic and try to sort this out. Now, one of the nice things about being a PH doctor is usually by the time someone comes to you, you know they have pulmonary hypertension, strongly suspected. Whereas the tough job out there is with the internists, family medicine docs, people that are seeing all kinds of different things, and someone comes in, they're short of breath, or maybe in the ED even, and the patient's short-winded. And now that it's COVID and they've got to decide what to do. Well, certainly if someone meets diagnostic criteria clinically, if someone's got severe shortness of breath that's not explained, or even moderate shortness of breath, you got to get a test. So what we tried to do in the pandemic, what we learned during the pandemic is an echo is really important. We knew that already, but echo is important, but we don't maybe need a right heart cath if all the other data fall into place. So to me, in an incident case, someone comes in, I think they got PAHs, they fit the phenotype, they've got unexplained shortness of breath, there's nothing on a chest x-ray, which maybe isn't too difficult to do. Exam, lungs are clear when the internist takes a listen to them. So the question, can you get an echo? Can you get some labs? And we've had Quest go out to get lab tests in patients' homes. That's one thing we learned in the pandemic. Someone can come to you and perhaps get blood testing, get a BNP, get lab values for us to make sure you're not anemic. That's not why you're short of breath. But the critical thing to me we learned about diagnosis is, you can make a pretty solid diagnosis, at least of pulmonary arterial hypertension, I believe, without a right heart cath. Now I know that's sacrilege to say that, but certainly in the prevalent patients, I'm not someone that caths someone every year. I just don't do it. I know many of my colleagues do no matter what. I don't need a cath every year. Talk to the patient, listen to the patient. You do a good telemedicine exam with the patient. Look at their neck veins, look at their legs, look for edema, and maybe with some lab tests, their oximeter, and some walking, I can get a pretty good idea how they're doing. Certainly in a stable patient, you don't need a cath. Now, in someone who's unstable, I think what we learned is we still have to rely on getting good diagnostic testing and labs, trying to get an exam, and in many cases, if we're going to get a drug approved, do a right heart cath. But to me, the bottom line, what we learned about making the diagnosis page during the pandemic and doing diagnostic testing is we can get by with a lot less. I had clinic yesterday and saw some of my regular PH patients that hadn't had an echo in 6 months. I like to do an echo in most people about every 6 months. These patients were stable, doing very well. I don't need an echo right now. I know how they're doing. I don't even need a BNP. Their ability to walk is the same. I ask them detailed questions about what they can do. I feel very comfortable I don't need an echo. Now, again, there are certainly cases where you do need these tests, so I don't mean we're eliminating them. But I think the bottom line to me is we don't need as many tests. We use our heads, talk to the patient like we did in the olden days, talk to them, listen to their symptoms. Maybe their family's on there too and fills us in. If you do that, I think you can get by with less diagnostic tests. And as the pandemic's gone along, we've gotten better at getting these tests done. So that's a few words on the diagnosis of PH during the pandemic. Thanks.